So our first presentation is on clinical research, what's on the horizon. And here to present on this topic is Dr. Neeraj Narula. Dr. Narula is an assistant professor of medicine at McMaster University and a staff gastroenterologist in Hamilton Health Sciences. He completed the President Levison Advanced Fellowship in Inflammatory Bowel Diseases at Mount Sinai Medical Center in New York, in 2015. He's a diplomat of the Program of Clinical Effectiveness at Harvard T.H. Chan School of Public Health in 2016. He trained to be a chartered accountant at the University of Waterloo and has worked at Ernst & Young and KPMG. He subsequently attended a medical school at University of Alberta. He graduated from internal medicine residency and gastroenterology fellowship training at McMaster University. His research interests are predominantly in clinical epidemiology, nutrition, and pharmaceutical trials in IBD. Please join me in welcoming Dr. Neeraj Narula.
So just an overview of my talk for this evening. We'll start with what is clinical research and why you may consider participating in clinical research. Then we'll discuss some current and emerging therapies that are being used for inflammatory bowel disease. And lastly, we'll discuss some studies that are currently ongoing at McMaster University. So to start off, we'll start off with what is clinical research and why consider participating in this. So the two main kinds of research I'm going to talk about today are clinical research and translational research. Clinical research is research really where people are the subjects being studied. People are the focus of the study. It might be looking at a drug versus a placebo for treating a disease. It might be just looking at patients who, for instance, have a surgery and try to figure out what kind of characteristics the patient might have that might predict that they may have a recurrence for Crohn's disease after they have a surgery. There's different kinds of clinical research. Not all clinical research is the same. This is in contrast to translational research. Translational research generally has a lab component. You might be taking some material or a specimen from humans and then examining it in the lab. For instance, sometimes you might be asked to take a blood sample. And the blood sample essentially might be looking at patients who have colitis, looking at patients who are healthy, and trying to see what kind of differences exist in the chemicals that are being released from those blood cells. Another example of translational research, for instance, might be taking stool samples from a colitis patient, taking stool samples from a healthy patient, and looking at differences in the bacteria that might be present. When you hear about clinical trials, the terms randomization, blinding, and control often are thrown around. And I'm going to give you a quick overview of what these terms actually mean. A clinical trial is generally something where we're trying to determine whether a new drug, device, or technique is actually effective and safe. If there's no standard therapy currently available for that condition, then often you'll see that a drug or intervention is actually compared to a placebo. Placebo is something that's meant to look like the drug or intervention that's being tested, but does not actually contain any active ingredient. Once there are standard therapies in place for a condition, however, then it may not be reasonable to compare a new drug versus placebo, and in some settings you may see a new drug being compared to a standard of care therapy or being added on top of a standard of care therapy to see if it's better to use that compared to just a standard therapy alone. So when you hear this term control, what that means is a standard comparator. It may refer to the placebo or it may refer to the known standard therapy. Blinding is a concept which essentially exists to help minimize bias. When we are involved with studies, we want to make sure the study has as minimal bias as possible so that we know what the answer we're seeing is likely true. Blinding refers to the idea that patients who are participating in the study or investigators who are administering the study don't know which patients are actually receiving drug or intervention and who's receiving placebo until well after the study is done and the analysis is being done. The idea here is that if you did know what the patient was receiving, then it may inherently cause some bias. For instance, if you have a vested interest in this new technique that you've designed and you really want to prove that it works, well, if you know that the patient that you're studying actually received that technique, you may be more biased or subconsciously biased to report that it's working versus someone who's receiving a placebo intervention. The same concept exists for randomization. Again, it's to help reduce bias. So the idea is that to decide who's going to receive drug or intervention and who's going to receive placebo, you essentially are randomly assigned to this, like pulling a number out of a hat or looking at a random number generator on a computer to decide who's going to receive drug intervention, who's going to receive placebo. And again, the idea here is to try to reduce the bias. If you knew or you could assign who's going to be getting a certain treatment, you may be more likely to try to assign that treatment to people who are perhaps more likely to respond. For instance, someone who has mild disease, and then the patients who have more severe disease, they get allocated to this placebo arm, and voila, your intervention looks great because it's helping all these mild people and the severe people aren't getting any better. So the concept is if you randomize patients, then there will probably be a similar number of mild patients who receive drug versus placebo, probably be a similar number of severe patients who receive drug versus placebo, and ideally things will kind of balance out that way. So why should patients consider participating in clinical trials? The main reason, quite frankly, is really altruism. It helps to advance methods that we have to diagnose, prevent, or treat disease, and it can really lead to advanced knowledge and decreased suffering in future generations. There may be some other reasons to participate. Financial incentives may be one. Well, typically there's not too much money here. You're not going to become a millionaire participating in clinical trials, but you may get a small stipend for helping, and it may help reimburse some of the expenses such as your time or parking and so on. In theory, you actually might get better care if you participate in clinical trials. There's often clinical trial nurses who are involved with the clinical trial, and you'll actually usually get really frequent follow-up with them. They'll make sure they're on top of what's happening with you. You have someone to call if anything is going on, and that's a little bit in contrast to what might happen if you're just relying on a physician to see you. Physicians are, as you may know, very booked up these days, and sometimes you have to wait several months before you can get in to see your physician next. So there may be a better care incentive as well to participate in clinical trials. And then lastly, you may actually get personal benefit from participating in the study. The drug that you're offered may actually improve your condition. It may be better than anything that's currently available. And we wouldn't know that unless you participated and helped these clinical trial programs move on. Another potential thing here is that some programs will actually offer you compassionate drug if you actually do respond to the drug after the studies have been over, for you to continue ongoing treatment as long as you're feeling well. Why do investigators do clinical trials? Well, the main reason for many is actually just out of interest and curiosity. And for me personally, it's out of frustration for some of the limitations that we have and what we can do for patients. And I'm curious about different ways that we can potentially improve disease and lessen side effects. There may be other reasons that clinicians get involved with clinical trials. It may be partly what they need to do in terms of getting promoted and moving up within the ranks of the institution that they work in. Financially, it doesn't tend to be a huge reason. You have to consider that most investigators are actually salaried at universities, and there's no financial incentive for them to be actually participating in clinical trials. And a lot of public grants actually don't include salary support for investigators either. Are there any risks to participating in clinical trials? Well, yes, but nothing in life is without risk. And one of the reasons that we're actually performing the clinical trial is to actually help evaluate what is the risk of using this medication. To help perhaps ease your concern is that if there are any risks that are determined when this new drug or intervention is being performed in animal studies, that's often not going to be moved to humans. Any human studies are closely scrutinized by ethics boards to ensure that the patients have their safety is looked after. For any known risk, investigators will actually disclose this to patients as part of the consent process, and they also disclose to you any measures that are being taken to help mitigate that or reduce that risk. And lastly, you always have the option to withdraw from the study should you choose. So now we'll switch gears a little bit. We'll look at some current and emerging therapies on the horizon. So I'm going to start this off by looking at some new drugs that you might hear about that have been approved recently in Canada or about to be approved, and you may be offered these drugs if you're going to be seeing one of your physicians soon if you haven't already been offered. Entyvio is a newer treatment that was approved for Crohn's disease this year in Canada, and ulcerative colitis just over a year ago in Canada. And it's actually a very exciting therapy. This is essentially a very gut-selective biologic that's administered by an infusion. And the idea that essentially blocks the inflammation cells from binding to the gut. This is a little bit related to a cousin drug called Tysabri that we used to use for Crohn's disease. And the concern that with Tysabri, if anyone's been on that, is that some people were developing this very serious brain infection. And it was thought that it was potentially related to these inflammation cells not being able to go to the brain and actually fight off that brain infection. This works a little bit differently. Like I mentioned, it doesn't impact the brain at all, it doesn't seem to, and really is quite gut selective, which has made it quite appealing. This was a study that was actually published this year looking at the overall safety profile for using Entyvio in ulcerative colitis and Crohn's disease. And essentially this is a compilation looking at all the patients who have been treated through the clinical trial programs that were using Entyvio. This is a bit of a busy slide, and you don't need to really look too much at the slide outside of the numbers on the right there that I've highlighted in red. And really what this report is the overall side effect rate in patients who are receiving the drug, the vedolizumab or Entyvio, versus patients who are receiving placebo. And you can see here actually that the side effect adverse event rate was actually lower in patients who were receiving the drug versus those receiving the placebo. And similarly, the serious adverse event rate was also lower in patients receiving the drug versus those patients receiving the placebo. We don't really commonly see that, and that is actually quite reassuring to us to think that really the adverse event rate on this medication is quite low. So what these investigators concluded, to also further add to the point, some of the other infections and things like that that we are also sometimes concerned about from some other therapies we use weren't really being seen here, and also there was no increase in cancer risk and that kind of stuff as well. Brain infection also had not been seen while patients were being treated with this drug. So the overall thought here is that the benefit-risk profile of this drug does make it quite a useful option for management of inflammatory bowel disease. Cordiment is another drug that's now available for us to use here in Canada. This has been available in the US as well as in Europe for at least a couple of years. And what this is essentially the second generation steroid that can be used for ulcerative colitis. The idea is that a lot of patients who have colitis are on these 5-ASA type drugs, and these are good drugs, but sometimes patients may relapse despite being on that drug. And the idea behind Cordiment is instead of offering them prednisone, which is a steroid that we often use that has a lot of side effects associated with it, we can use this drug, which actually has more of a local delivery to the colon. You can see that nice picture there where you can see the labeled drug that's actually being taken up mainly in the colon. And it doesn't seem to really have much in the way of side effects like prednisone does. I'm going to show you this graph here. Just want you to look at the right there where it says glucocorticoid-related adverse events, and the patients who receive the budesonide MMX or the Cordiment are those depicted by the blue bar, and those patients receiving placebo are those in the red bar. And really you don't appreciate any significant difference in side effects that could be potentially attributed to steroid when you're looking at patients who receive the budesonide MMX versus those patients who are receiving placebo. So the thought is that this is looking like it's pretty safe, and we're not really seeing any increased side effects even compared to placebo when we're specifically talking about things that look like they might be steroid related. The last drug I want to quickly talk about is Stelara, ustekinumab, and this is supposed to be coming very soon officially in Canada for Crohn's disease. It's often actually already used off-label for Crohn's disease, but the recent studies have been published and they look very promising for the treatment of Crohn's disease, and my understanding is December is when we should be expecting it, so quite soon. This is exciting to us and for patients who actually come to McMaster. McMaster was one of the centers that was participating in the Unity trials or the Stelara study, so we're quite happy to see that the drug ended up doing quite well and is going to be approved and available for patients who have Crohn's disease. So looking at some alternative therapies on the horizon, certainly things that I often get asked about. One of them is fecal transplant. Fecal transplant is something that we have been using for a while, especially in C. difficile infection. And this essentially is actually considered to be a cure for C. difficile infection in many cases, almost 95% of cases. And we were seeing in patients who had inflammatory bowel disease who also developed C. difficile infection that when they had received the fecal transplant for their C. difficile infection, many of them actually reported improvement in their inflammatory bowel disease. And I think the appeal is to both the clinicians as well as to patients that this is kind of a natural approach to treatment and doesn't require long-term immune suppressive therapies. And the very first case report of fecal transplant in ulcerative colitis was actually a physician who self-administered stool enema for 6 months and was able to demonstrate that he had clinical as well as improvement on his endoscopy when he had looked at how he did over the 6 months' time. Subsequently, there have been many small case series and case reports that have looked at using fecal transplant for inflammatory bowel disease. Some of them were positive, some of them were negative, and some of them even suggested that there may be even some side effects from this thing that we didn't really expect, like worsening inflammation after receiving the fecal transplant. So what this means is there was some equipoise, we didn't really know what to do, so we got some clinical studies that have looked at this, and there's now been reported 3 randomized clinical trials that have looked at fecal transplant ulcerative colitis. One of them was done here by Dr. Moyetti. And this essentially looked at giving stool enema once a week for 6 weeks compared to giving water enema, and almost 25% of patients who had received the fecal transplant were in remission at the end of the study versus 5% of those patients who were receiving placebo. This difference was statistically significant. There was another study that came from Amsterdam. This was looking at 37 patients. There's a slight typo here, but really what happened here is they essentially got a FMT, they got their fecal transplant by ND tube, which essentially is a tube that goes to the nose and into your small bowel. And that was compared to people who had autologous fecal transplant, i.e. taking that person's own stool and administering it through the tube. And in this study, they said 30% of patients who received fecal transplant versus 20% of patients who had received their own stool were in remission at the end of the study. It's quite a small study, but this wasn't a significant difference. And then most recently, there's been a group out of Australia that had reported their experience, and the way they delivered the fecal transplant was initially by colonoscopy, and then they gave very intensive stool enema regimen 5 times per week, or placebo, and they reported, similar to the study that was done here, that about 27% of patients were in remission after the 8-week time frame versus 8% of patients who had received placebo. This is just a graph that came from the study that was done here, and it just gives you a kind of an overview that the stool that's being administered to each patient could be quite different. And we see these are the 6 donors that participated in terms of providing stool for the study, and I want to just highlight donor B. And you can see the composition of bacteria in donor B is quite different than the other neighboring patients here. And many patients who actually received stool from donor B actually had an improvement compared to patients who had received stool from other donors. So that suggests that there may be a particular bacterial profile that may actually work for this, and I think that's one of the unanswered questions. So why do we see different results in these 3 studies? Well, one might be the type of patients who were selected for each individual study. There might be this donor B effect, i.e. if you're giving certain stool that actually has very good bacteria, which we don't really know which ones are the good bacteria yet, then perhaps patients are more likely to respond to that. These studies may not have had enough patients to actually shown really dramatic benefits, especially that study that came from Amsterdam. And then you see that there's different treatment protocols that are being used. Some studies they're using initial colonoscopy, then enema. Some studies are using this ND tube, so that's a little bit of a difference in some of the studies here. Some studies let patients continue their ongoing therapies. Some studies require patients to stop their ongoing therapies. And we know that there's other things that can even change the gut bacterial flora. If you take a preparation for a colonoscopy, even that's been shown to change your flora. So there's a lot of potential variables at play. So I think from this, we actually have a lot more questions now than we do have answers. One is it effective? We have a couple of studies that are saying, yeah, it looks like it's effective. One saying maybe not. We don't know if we should be just doing this as a sole therapy or should we be just adding it on top of other therapies. We don't know which route is best. And we don't know if this is really something you just need to do for short term, or is this something that needs to be done long term. We also try to determine which patients may benefit most from this. Is it patients who have relatively early disease, they've only had the disease for a few months or a couple of years, or will patients who've had the disease for a long time also benefit from it? And if you do demonstrate an initial response, do you need to actually be continuing on this as a maintenance treatment per se, or can you be good off this treatment for a long time? Again, a lot of questions we have, don't have all the answers yet. So currently what we recommend is that this should really be done in a research setting, and I wouldn't recommend trying this at home. We don't know the long-term safety yet, and there has been some case reports of patients who had received fecal transplant and go on to develop other problems like rheumatoid arthritis or other immune-mediated diseases. I do think you were seeing a lot of quickly moving studies here, and I think we're going to have a lot more answers soon. But for now, I would recommend sticking with traditional therapies. And lastly, I'm just going to give a quick overview of some studies that are ongoing at McMaster. And this is a slide to just kind of highlight that we always have a lot of studies going on. And if you are a patient that potentially is running out of options, or you're really just interested in potentially trying something different, or you don't like what you're currently receiving, we have potentially other options for you. And I'm going to give a plug for a couple of studies that are happening here. One of them is by Dr. Moietti again, looking at fecal transplant. And this study is actually looking at whether antibiotics are necessary when you're about to receive your fecal transplant or not. So patients are actually being randomized to antibiotics versus not. And then actually all patients who participate end up getting the fecal transplant, and they're all coming from that donor B. So this is something that I think we're all very excited about. And if you are interested in participating, the study coordinator's information is listed there, and she's happy to take your query by email to see if you might be potentially eligible. It's a study that I'll be starting in the spring of 2017, and this is a study that's looking at an exclusion diet that I designed that I think potentially removes some food compounds that might be pro-inflammatory, and essentially we'd be looking to give you an oral feed by enteral nutrition or liquid feeding, see if you respond to that after a couple of weeks, and if so, transition you to this exclusion diet and see after 12 weeks if this has led to some improvement. We'd be looking at a lot of objective things like repeat colonoscopy to see if there's healing of the bowel, as well as changes in stool and blood tests. So if you're interested, please feel free to email me there, and when the study is about to start recruitment, I can be in touch. And that's it. Thank you very much.